Good evening, everyone, and welcome to our Family Medicine Residency Virtual Showcase. I'm Scott Allen. I'm the CEO for the Family Medicine Education Consortium, and we're excited tonight to hear from Lancaster General Health Penn Medicine Family Medicine Residency Program about obstetrics and family medicine and about their program and all the great things it's doing. We have a number of people from the program here, including Dr. Pam Benenchek, and they're going to take it over in just a minute after I tell you a little bit about FMEC. So hopefully most of you know who the FMEC is. We are a catalyst, convener, and incubator that works with academic family medicine programs. Really, I think of our goals as threefold. One is to encourage medical students to think about family medicine and primary care for their specialty. A second is to help support family medicine residencies during their training, to do scholarly work, to do presentations, to meet with each other and learn from each other. And the third is to support the faculty of those programs to get together, do learning collaboratives, take advantage of the network we have throughout our 14 states. We do cover 14 states in the Northeast US, plus the District of Columbia. In that region, there's about 60 medical schools and actually over 200 family medicine residency programs. We do an annual meeting each fall, so hopefully you're all aware of that, and many of you as students might be actually coming on scholarship, so we look forward to seeing you. That meeting is in October 13th through the 15th in Providence, Rhode Island. And if you're not coming for that one, then please put on your calendars to come to the one in 2024. That's September 19th through the 21st in Philadelphia, Pennsylvania. So with that, I am going to turn it over to Dr. Benenchek.
Hi, everyone. I'm Dr. Pam Benenchek. I'm the program director of Penn Medicine, Lancaster General Hospital Family Medicine Residency. And I am really excited because I have several of our residents that are joining us, and I'm lurking because also one of our OB faculty will be joining us. So I'll have our residents introduce themselves, and then what I plan to do is talk a little bit about our family medicine residency in general, talk a little bit about how we do our obstetrics training. I'm going to talk a little bit about maybe the state of family medicine obstetrics across the country, as well as I think what are some opportunities for family medicine in obstetrics and how we can fill a big need. So without further ado, Laura, if you would introduce yourself.
Sure, thanks. I'm Laura. I'm an intern. I went to Rutgers, New Jersey Medical School, and I just had my OB rotation last month, and I absolutely loved it. So super excited to be on this call and talk to everyone about it.
Jeremiah.
Hey guys, my name is Jeremiah. I use he, him pronouns. I am a third-year family medicine resident, and I am enjoying my OB experience so far, and I'm hoping to eventually do an OB fellowship.
Marco.
Sorry, having technical difficulties. I'm Marco Funicelli. I'm also a third year, use he, him pronouns. I love doing OB. It's one of the highlights of my year. And I am hoping to continue doing OB in practice in the future when I graduate.
Excellent. And Charisse, have you been able to join? It looks like she's not on yet, but I'm sure she'll be on in a little bit. I was just talking with her. So I am going to share my slides. I'm just going to talk for a few brief minutes. And like I said, I'm hoping it will just spur some discussion, spur some opportunity for questions. So give me a second as I get used to using Zoom. Great. And just switch to slideshow. If someone can unmute and confirm that I am actually sharing my screen.
We see them.
Yay. Okay, super. All right. So a little bit about Penn Medicine, Lancaster General Hospital Family Medicine Residency. We are the only hospitals, I'm post-call for OB. I did a night shift last night. So so if I misspeak, please catch me or correct me, LGH team. So we are the only residencies sponsored by our hospital. And so sometimes people call that an unopposed residency. I think I don't like that term, but just for perspective. We have 13 residents each year, and we are a 3-year family medicine residency. And we were established over 50 years ago. We were one of the 15 original family medicine residencies that were started in the United States. Our residency program is well known for being a strong full spectrum family medicine residency. We have strong inpatient experience, strong outpatient experience, and a strong maternity experience. And also we have the opportunity for residents to really tailor their curriculum to what they're interested in. We are very unique in the fact that we have 2 family medicine centers that all residents have practice. We have an urban center called Downtown Family Medicine, which is in the city of Lancaster. And for those of you who aren't familiar with Lancaster, we're a city of about 50,000 people in a county of about 500,000 in southeast Pennsylvania. And Lancaster City is a very diverse city. About 40% of the population is Spanish speaking, about 18% identify as Black, about 10% Asian, and the rest Caucasian. And a few years ago, the BBC labeled us as the refugee capital of the United States because per capita, we have such a large refugee population. And so that's where our urban center is. Our rural center is about 14 miles south in rural Lancaster County in Quarryville at the Walter Ahmet Family Medicine Center. So our residents all have urban and rural experience. Our main inpatient experience is at Lancaster General Hospital, which is a 500 plus bed hospital where our residents do their emergency department experience, inpatient pediatrics, and inpatient medicine experiences. 3 miles down the road, we have Women and Babies Hospital, which is a 95 bed hospital where the labor and delivery experience, newborn nursery, NICU, and GYN experiences are. Our residency program has over 21 areas of concentration. So for residents who want to focus on a particular area of interest, such as HIV medicine, integrative health, sports medicine, adolescent medicine, street medicine, geriatrics, and the list goes on and on. You have the opportunity to do that. And a new addition to our program is we were awarded osteopathic recognition this past July. A little bit about the family medicine maternity care requirements from the ACGME. As many of you know, the ACGME Residency Review Committee for Family Medicine revised the family medicine program requirements effective this past July. And there have been some exciting developments in the maternity care requirements. All residents must have at least 200 hours or 2 months dedicated to the care of maternity patients. This experience must include structured curriculum in prenatal, intrapartum, and postpartum care. Residents must care for pregnant patients in the outpatient setting, including prenatal care and care of medical complications in pregnancy. I'm just going to move this little window so I can see all my slides. There we go. Okay. Each resident must have experience with a minimum of 20 vaginal deliveries, and residents should care for postpartum patients, including paternal baby pairs. Residents who seek the option to incorporate comprehensive pregnancy-related care, including intrapartum-related care, must complete at least 400 hours or 4 months dedicated to the training on labor and delivery, or perform or directly supervise at least 80 deliveries. So that 80 number is really important if you plan to do maternity care in your future practice. So how do we do our maternity curriculum at Lancaster General? So all residents have 5 months of maternal child health experience. There are 2 in the intern year, 2 months in the second year, and 1 month in the third year. And we give our residents the option to trade, so they can actually add an additional month in their third month if they choose. And Jeremiah is one of those who has chosen to do that. All of our residents have the ALSO course, which is the Advanced Life Support in Obstetrics course in February of their intern year. Our faculty that train residents include 12 family medicine faculty, plus a number of family physicians from the community, from a local federally qualified health center. We have 8 OBGYN faculty who are dedicated as our backup and take call with us. So as an intern, when you are on your OB experience, you are on with an upper year resident, a family medicine faculty like me, and an OBGYN faculty like Dr. Hamblin, who I see has joined us. And so you are very well supported when you are on your labor and delivery experience. Last year, our residency delivered over 1,000 babies. And just for some perspective, our residents who are interested in doing maternity care can easily get to 80 to 100 deliveries by the time of graduation. Those who aren't so interested usually graduate with about 40 to 60 deliveries. And we care for a very diverse population. We care for prenatal patients from both of our family medicine centers, the urban one as well as the rural one. We also, about a third of our deliveries come from our local federally qualified health center, which is a very diverse population. And then we also deliver patients from several community family medicine centers, as well as our OBGYN practice. Our residents have a lot of experience doing prenatal care. Some of it is traditional prenatal care in our family medicine centers, but we also have centering pregnancy, which is group prenatal care. And so pre-COVID, we truly did this group prenatal care where birth parents and partners and sometimes their kids would come and residents would facilitate these groups. And we fully intend to get back to doing that group prenatal care, but what we have been doing with COVID and we're still kind of lingering on and trying to make the transition is we've been scheduling the cohorts of women. So you know when you're going to be doing your OB rotation. So say Jeremiah is going to be doing OB in December. He and another resident partner are assigned a cohort of women who are due the time when he's going to be on OB, and as a group sees those patients throughout their prenatal course. And so when he is on labor and delivery, those women are already scheduled. So it's a great way to introduce continuity. Our residency program has been very active with the Implicit Project, which is a project through the FMEC and is a collaboration now of over 35 residency programs and health centers that is working to decrease prematurity in low birth weight infants. And so we have been involved in a number of quality improvement and research projects with them. And we have a very active fourth trimester project. And so many of you are familiar with the fourth trimester concept, which is that 6 to 8 weeks after delivery, really focusing on care and screening for moms to make sure they have adequate contraception. There's depression screening and close attention to their medical complications. So looking at some data from the American Board of Family Medicine, in 2000, so now 23 years ago, approximately 23% of all family physicians provided some maternity care. By 2019, that decreased to about 8%, and there's some data to show that it's even less than that now. So, which is somewhat disheartening to me for sure. Looking at a survey of 2020 graduates, if you look at across the board, across the country, 13% of family medicine graduates are delivering babies. If you look at the Lancaster General 2020 graduates, 29% of our graduates are delivering babies. Residents, so when you're looking for residencies and you're thinking that you want to provide maternity care, you want to look for residencies that have family physicians doing deliveries and precepting. You want to make sure you will have the ability to get over 80 deliveries during the course of your residency, and programs that allow for greater autonomy in maternity care decision making are all factors that are associated with an increased likelihood of actually doing deliveries. And family physicians with advanced training can perform C-sections. And so residency programs provide varying levels of experience and exposure to C-sections, and then there are a number of fellowships, and as Jeremiah mentioned, he's considering doing those. So looking at family physicians who are in practice, how many deliveries a year are they doing? So if you look at 2016, for which the most recent data is available, about 5% are doing very low volume obstetrics of about 1 to 25 deliveries per year. About 2% are doing medium volume obstetrics of 26 to 50 a year. And then a smaller percentage are doing over 50 deliveries per year. Turning to what I see as the big opportunity for family medicine, there is a maternity access crisis in rural America in the United States. In the United States, 28 million reproductive age women live in rural communities, and more than half of rural communities in the United States do not have hospital-based obstetric services. And so looking at this map, this is a map looking at U.S. counties from 2004 to 2014. So yes, this data is like 10 years old. But during that time period, 179 counties in the United States lost access to in-county obstetric services. And between 2014 and 2018, another 53 counties lost access to maternity care. And so if you look at this map, Black counties had, the Black indicated counties had full closure, dark blue counties have no services, and the green counties have kind of have partial services. And if you look in the middle of the United States and down south, there's a disproportionate number of counties where there is not maternity care. And in particular, majority Black rural communities are more likely to lack OB services. And this map is also just another visualization of a decrease in the number of hospitals that are provide OB services. And so ACOG has recognized that most rural counties don't have any OBGYNs. OBGYNs tend to prefer to practice in more urban areas where they're going to have higher volume of cases and more complexity of cases. Family medicine physicians and residents are more likely to provide maternity care in rural areas. And greater travel distance to maternity care services is associated with worse prenatal outcomes. And the decreasing percentage of family physicians that are providing prenatal care and intrapartum care have contributed to the increase in the number of rural communities that do not have access to maternity care. And so there just are not enough cases in rural America for OBGYNs to deliver the majority of babies. Family physicians who do maternity care are well poised to provide service to these women and close these gaps, because family physicians, when they're not delivering babies, can address all the other patient concerns of families, can take care of children, can take care of adults, you know, regardless of their conditions. And of note, maternal and child outcomes are similar between family physicians and OBGYNs providing maternity care. This is some comments just from a recent paper that was published in the Journal of the American Board of Family Medicine from 2017 to 2022. Over 28,000 family physicians responded to an ABFM survey. And so of those physicians that responded, just over 2% provided C-sections as primary surgeons. And the demographics of those that do provide C-sections, they tend to be male. They tend to be working in rural health clinics, in small rural counties, and in counties that do not have OBGYNs. And so family physicians can really be an important workforce to maintain and potentially expand access to rural maternity services. I am going to stop there and stop sharing. Dr. Hamblin, I see you joined, and would you please introduce yourself as another member of the LGH family?
I think Dr. Hamlin sent a message that she is unable to hear or talk.
Oh no.
But she did send a chat message.
All right. So Dr. Hamblin, wave. All right. And then Dr. Fogelman, I see you also joined. Do you want to introduce yourself?
Hi, I'm Corey Fogelman, and I'm one of the other faculty members at family physician at LGH. And I also do maternity care and deliveries and supervise the residents at Women and Babies Hospital. And I was on call 2 nights ago, so I am slightly more recovered than Pam is. But you did a great job, Pam. I also usually like to tell, prospective residents that, I love taking care of children in the clinic, and I love and part of my decision point in choosing family medicine was whether or not to be a pediatrician, because I like child care or taking care of children. And one of the things that a faculty member told me when I was in residency was, if you really want to take care of kids as a family physician, the best way to do that is to continue providing OB care so that you can deliver those babies and keep those infants as part of your practice. And that has really stuck with me. And it's one of the reasons that I've continued to do OB low these many years. So besides the fact that it's a lot of fun. But
I'd like to
I also do
centering.
I also am one of the centering providers and do hope to bring that back to our residency program. I was a champion of that for many years. And I've also been working on the implicit project for 15 or 20 years now, and have enjoyed the opportunity that family physicians have to intervene on behalf of our mothers during well child visits. You can treat 2 people in the room at the same time. So whenever I'm I have medical students rotating with me in clinic, and they say, what's it like when the mom says, do you mind if I have a problem that you can answer for me during the well child visit? And I say, it makes me feel good as a physician to be able to say, yeah, no problem. I can open up your chart and answer your question, and maybe even help you with prenatal vitamins or prescription or something else. So that's part of what implicit has empowered us to do. And I'm happy to talk more about that at some point, but I'll mute. Sorry, go on and on.
I'd like to open it up for questions now. You can either unmute if you feel bold, or if you want to put it into the chat. hopefully I will not be speaking, and I'm going to have the residents and Dr. Fogelman try to answer as many as possible.
I have a question. Yes?
Please,
Okay.
go ahead.
Thank you so much. It was really very interesting to know about the program and to listen to you. And I see that you are shining after the night of to be delivering babies. My name is Lina Cherzian. I just want to give you some little bit about myself. I did my residency in OBGYN in Syria, and I really it was interesting for me, and I finished 4 years, and I came to this country, and I went to medical school in osteopathic medicine, and I'm really interested in family medicine because I felt that, as you mentioned, in rural area, that they do need a person who to be their family medicine practitioner and to provide an OBGYN, especially in those. I traveled a lot, and I'm still traveling, and maybe I noticed it mainly in Arizona area sometime, and in New York, around New York area. I didn't travel too much to Pennsylvania unless for to take my CS exam and PE exam. But I am really interested in rural area to do OB. But for example, you mentioned about that people resident in family medicine, they are allowed to do cesarean section. I'm just wondering, can you just a little bit explain to us a little bit more? Because I have a very good experience with all the surgery, hysterectomy, all of those. Can you just a little bit give us about, are they going to be the main surgeon to open the OB, the cesarean section, or they are going to be a first assistant? How it's going to be? Thank you so much.
Great question. Corey, do you feel comfortable taking that, or?
Yeah, it's no problem. So yeah, at our hospital, we assist, but we do not. We're not the primary surgeons to help with our C-sections. Our residents are welcome to go into the operating room with our OBs, but you will not leave LGH being trained to do cesarean sections. That being said, we do get a fair amount of sort of higher risk OB experience. And so there are plenty of high risk things that you will leave LGH feeling comfortable taking care of. But to answer the question about cesarean deliveries specifically, that is not something that we can train you in. And that would be something that we would expect, if you had an interest, you would want to pursue an OB fellowship, as Jeremiah has plans to do. In terms of rural America and why cesarean deliveries are necessary, again, they have a lack of primary surgical access in rural America, and part of our mission is to train rural Americans to be able to deliver good quality OB care. So we consider ourselves a part of that training process, but we're not going to fulfill that completely at LGH at this point.
And just a comment just about cesarean section in rural America. Some of the data that I presented, in many counties, family physicians, doing cesarean sections will be the primary surgeon. And so, like, for example, I was talking recently with someone who was interested in a faculty position at Lancaster General, and she is practicing in rural Idaho in a group of 4 family physicians who they're the only ones in their county who are doing cesarean sections and are taking call on cross covering. So, right, even though at our residency, we're going to get you experience, we're going to get you exposure, you can do electives, with additional training, you can be the primary surgeon in rural areas as a family physician.
Thank you so much for answering my question. It was a pleasure.
Hi, my name is Jennifer Hardell. I'm applying this year and very interested in your program. So thanks for having this session. I was curious about like kind of your fourth trimester training, and like I know there's also like centering, I think it's called parenting, kind of a similar thing except for well child visits. And I'm just curious about if there's any interest in doing that sometime in the future, and also like what kind of, I don't know, like lactation training do you guys have, or what kind of education you get on that front?
All right,
I hate to be the only one who's talking,
unmute.
but
yeah.
I can speak
I
to
can
the.
take that.
Okay.
Or yeah, sure, whatever. So as far as the to my knowledge, I'm not one of the higher ups, so I don't know if we are like if we have looked into doing like the centering parenting. We do the centering pregnancy, and that's been a part of our program for a long time. I'm not sure where things are with regards to centering parenting. For the fourth trimester thing, that is something that we really try to make a standard in the care that we provide, which is exciting because I think more and more people are recognizing the importance of earlier follow-up than just the 6-week postpartum visit. And so it is exciting to kind of be on, in a sense, like the front lines of that paradigm shift. And I, for example, I'm actually working with Corey on like a fourth trimester qualitative research project to try to figure out how we can improve that model further. And we're doing that in conjunction with Rochester and UPMC, two programs that I've also been very involved with, the implicit network and the fourth trimester project. I would say it's less like, I don't know if I would describe it so much as like being trained in the fourth trimester as it is just like, incorporating it and, effectuating it to the best of our ability, which I guess is training. So anyways, whatever. As far as the lactation training, we have one of our second year MCH months, that's our nursery rotation, and that's where we do a lot more focus on the newborn nursery experience, which includes lactation. So whereas, of our 5 core months, the first 2 intern year months are more focused on just getting comfortable with L&D, intrapartum management, postpartum care. And then in the second year, you have one of those nursery months where you are able to focus more on that parent-baby relationship. So you're doing things like rounding with lactation. We have faculty that are kind of coordinators of those rotations, and so they kind of get us plugged in with like breastfeeding modules that we review before the rotation, just to kind of help us with our counseling, because it is kind of a very foreign and new topic for a lot of folks. And then Lancaster, or Women and Babies Hospital, is also like a baby friendly hospital, or I forget exactly what the phrase is. The breastfeeding, we like breastfeeding certification. I don't know.
It's baby
and,
friendly. Mm-hmm.
Yeah. And so I think because of that, we have very helpful access to lactation, and promoting that in our rounds is a common thing that we kind of get comfortable with doing. So that's kind of the resident experience.
Can I add one thing, Jeremiah?
Yes,
Can you
yes,
guys
please
hear?
do.
Yeah, okay. I was like, wait, can you hear me? We also have one of our faculty members is IBCLC certified lactation consultant too. So she's provided some education in our block conferences and morning reports and things like that, and just serves as a resource if you have any additional questions. So that's really great.
Um,
Can we ask
Sharice,
more
thank you.
questions or no?
Oh.
Are we allowed to ask more questions or are we done?
Of course, of
Okay.
course.
Don't hold everybody. So I had a question because I just recently completed a rural medicine rotation. Really liked it. A lot of fun. Get to do pretty much everything. Kind of fly by the seat of your pants. So I had a question. With this implicit training, you're kind of treating everybody in the room kind of thought process, mother and children. Does that kind of carry over to other areas of the program too? Like if you're in a rural clinic, do we treat everybody that comes in, or is that just specific to the mother and children?
That's an awesome question. Residents, do you want to comment on it?
I can take that one. So yeah, I think it really does. Especially in our more rural clinic, we have walk-in patients all the time. Since it's more of like a rural setting, often patients don't want to go to the emergency department and things like that. So they will, come to the clinic. And there's always a designated acute care provider who can, we can fit them in to help with whatever their needs are. And I mean, we do stuff like that in our regular practice as well. I think somebody is not muted.
Is it
Can you guys
me?
still hear?
I'm sorry.
No. Oh, yep. There we go. Yeah, and then in our regular clinical practice as well, it's one of the benefits of having an electronic medical record is if your patients bring up certain concerns, like, hey, I need this prescription refilled, I ran out of it, or my son needs this school note that was supposed to be given last visit. You can just kind of pop over to their chart and take care of a couple things in one visit. So that's one of the benefits. I will say the most times we do use it, I find, is in well child checks where you're checking in with moms on birth control, prenatal vitamins, that kind of stuff, sending in prescriptions for those if needed. But there is definitely no rule that says that we can't do that. So we take full advantage of it.
That's awesome. Yeah. I really just like that thought process. If you come in and, well, hey, you're both my patients or whatever, and somebody else has an issue. All right, let's do it right now. You're already here. Let's just get it done. But no, that's great that you do that. Thank you very much for answering.
I love all the questions. I see two hands up, but I want to actually give Corey a chance to respond to one of the questions in the chat about exposure residents get with managing substance use during pregnancy.
Can you hear me?
Yep.
Okay, good. Sorry. Yeah, so we have a lot of experience taking care of substance use disorder in our area. All of our providers were ex-waivered before the elimination of that requirement, and our faculty feel comfortable supervising our residents in the inpatient and outpatient setting, doing both Suboxone and methadone treatment. We don't manage a methadone center, but we do take care of a lot of those patients in the inpatient setting. In terms of women and pregnant patients who are delivering and on substance use disorder, we have a fairly robust relationship with the NICU and nursery in our facility, and we are champions of the Eat, Sleep, Console method of postpartum management of babies. So we try to keep babies with mother during that critical period when they're first born after exposure to opioids during pregnancy. In addition, we're the primary care providers for a local women's recovery center and we deliver their babies as well. And that's a 6-month inpatient low access hospital nearby where we manage those patients. And then again, they come to Women and Babies if they need to deliver. And our residents rotate there and work with them in their groups and help supervise their recovery process. I'm happy to answer more specific questions about that. But thank you. That was an excellent question. I appreciate it.
Let's see. We'll do. Oh, I'm not gonna do your name correctly. Joytan and then Roshan.
Hi, yeah, this is Jyotan Sahani.
Thank you.
Thank you for having us. So I'm a non-traditional candidate with OBGYN residency from India and working in a high volume obstetrics. So I have teaching experience, research experience in US, and presently for the last 1 year, I have been working as a house physician in New York. So my question is that, do you have any hard filters on year of graduation, or you go by case case to case basis, and you welcome life experiences too?
So we do value life experiences, and so for folks who are farther out from graduation, if they have been had clinical experience in the United States, we do take that into account.
Thank you so much.
Rashawn.
Hi everyone. Hi, my name is Rashawn. I'm a 4th year at PCOM in Philadelphia. I wrote my question in the chat, but I will reiterate it. My written communication is a lot better than my verbal communication. I was curious about how discussions about like maternal mortality and the need for a diversification of the clinician workforce fit into the curriculum, fit into the obstetrics curriculum, and if there are any opportunities for residents to get engaged in like quality improvement projects to help meet the need and improve maternal outcomes across the board, but especially for Black mothers.
Which of our team wants to start with that? Because we have a lot. I really wish Dr. Hamblin could unmute. This is her.
I see Dr. Hamblin responded in the chat.
She's doing great, but but Corey or
yeah, we have
Jeremiah.
several. Yeah, I mean, I'm happy to start. We have several PI projects regarding BIPOC patients and maternity care, and Dr. Hamlin helps to lead some of those. First of all, process improvement projects are very well supported and encouraged at our program, as I think that they are at most residencies. We do have a research center here that helps. It's kind of unique to have that in a community hospital setting, and fairly robust funding available for a lot of projects. If you have a research need and you want to do randomized control trials, drug, we can make that happen. But in terms of supporting our local community, we have a pretty engaged bioinformation. Was it a bio? Basic what is the new abbreviation for the folks who do the statistics for us, Pam? I can't remember right now. Anyway,
business intelligence.
Business intelligence, that's what it is. Yeah, sorry. I knew it was BI, but anyway. So they are real great about like helping us formulate questions and digging into the local data with regard to percentage of patients and percentage of pathologies and so forth, and then helping us design our projects and getting moving forward on successful completion. But yeah, so if you have a specific desire when you arrive, we can try to help that make that happen for you. If on the other hand you arrive and you're like, I'm not sure, but I want to join a project, we have several big projects that need ongoing work, and so, that's kind of thing that Implicit provides for us. It's an ongoing area for process improvement. And I don't know that I answered all of that. PRW is the patients are waiting, and that is, for those of you who do not know, that's an organization begun by and founded by Dr. Hamlin, one of our OB-GYNs, and she recognized the critical need for more Black and Latinx providers in our area, and said, I can do something about this. I can go to high schools, I can go to colleges, I can, and so she's made a systematic approach to recruiting. And as a member of our faculty, we're the beneficiaries of the education that she does in our local community, and as well as the recruiting that she does for our residency itself. And I can say I've certainly grown as a person and as a provider through the good work that she has done there as well. And so PRW, Patients Are Waiting, always has projects going that many of us have jumped in and tried to help with. So
our residency has been making very intentional recruiting efforts to have our resident and faculty complement reflect the city that we work in. So with particular emphasis on recruiting BIPOC populations, and our current intern class is 40% BIPOC. So we're really excited about some of the efforts that we've been making. And Dr. Hamlin has been the lead on those efforts. Laura, Jeremiah, or Marco, I was wondering if you wanted to talk about any deliveries where you've had the opportunity to work with some of the doulas from Diversifying Doulas.
Sure, I can talk about that. And even outside of deliveries, pretty much all of our exam rooms in our downtown clinic have flyers in them about our Diversifying Doulas program. So that's usually part of most of our intake visits for our prenatal patients, is providing them with information on that resource. And many of our patients really utilize it. Part of what it looks like is I've had patients who their doula comes to all of their prenatal appointments with them. I've had people who their doula is their only support person for their entire labor course and is there with them throughout the labor and delivery process and even beyond. And you get to know some of the doulas. You see, there's a few that you see at Women and Babies Hospital all the time, which is really great for building community and also forging those relationships to really connect your patients to people who you know and you trust and you've seen have really helped people in the past. So I've really enjoyed working with the doulas. And it really is kind of a group effort on labor and delivery sometimes, especially for our first-time moms. And they've been really helpful in keeping the delivery room calm, helping the patient coach through a really difficult period of time in their life, and celebrate with us in the end.
One of our deliveries last night was a prima gravida who did not have any pain medication or epidural and pushed for 3 hours and 15 minutes with her doula, and it was an amazing experience. And this woman clearly would not have been able to do it without her doula. It was really wonderful.
And in that same vein, I just wanted to say another really cool thing that the doulas do is they're really advocates for the patients too. Not just with us as their physicians, but also with the nursing staff who's with them throughout their labor course. sometimes pain makes you want to change your mind about things that you've, had in your birth plan since day one. And I feel like the patients who have had doulas have been really much more likely to stick with their original plans, which I think is really.
Pam, I think Aaron has a question.
Go for it, Aaron.
Yeah, I'm Erin. I'm a fourth year at Rocky Vista University in Colorado. And I was just wondering, what does the typical schedule look like when you are on your OB rotation? Are you covering everything from labor and delivery to postpartum and triage, or is it kind of broken up as you go through the rotation?
I can answer this one. So basically, as the intern, I mean, you have the support of the senior, of course, as well. But you are basically going through everything all day. You are on the intrapartum floor. That's priority number one. And then there's triage as well. And if there's something really important there, you're going there. And then our postpartum patients too. So you're kind of doing it all day. And I think one of the hardest parts about the OB rotation is prioritizing, but it's something you really get good at by the end of the 4 weeks, and your senior is helping you through the whole thing.
And
Thank you.
oh, yeah, as one of the upper years, we do try to be pretty intentional about like making the kind of like increasing your responsibilities as the rotation goes along for the first rotation. And I think Laura had her rotation second or so, and probably remembers, like during that first week, like if we're all seeing patients in triage, like, the intern might see one, and then like the senior might see like, the other 3 or 4. And you do definitely have a lot more guidance in the first rotation, like figuring out how to prioritize things, because it is a lot to balance when you're kind of learning a lot for the first time. And then as your second month comes around, then you're slowly getting more and more responsibilities. And then being the upper year, the following year is also a learning experience as well, that it doesn't just like the support doesn't just end with your senior resident, it also goes to your attending too. And the attendings are generally very supportive of helping the senior learn how to senior, because it is one of those things that also a part of residency is learning how to manage a team. And that is one of those things that you don't necessarily always think about as being a part of being a doctor in medical school, but it very quickly becomes apparent that it's an important thing to learn how to do. And I do think that you really get good at managing a busy service and feeling like you come out of that with a lot of tangible skill.
Yeah, we all really work as a team the whole time, like the senior and the family medicine preceptor, as well as the OB attending too. So there's a lot of support on that rotation to like just get better at prioritizing things.
Brandon, you have a question.
Hey, thank you all for hosting this session. You presented a lot of good information about like the state of FM doctors in the U.S. that are practicing OB. I was wondering if you had any data or numbers on like the percentage of your residents from your program that are continuing to use OB in their practice after graduation.
Yeah, so in that 2020 year, so the cohort that graduated in 2020, so just about 30% of the residents that year, our most recent set of graduates, 4 of the 13 are doing maternity care. So it's been staying pretty stable at about, 30%. Some are doing deliveries, some are just doing prenatal care, some are doing combinations of both. So our graduates are actually able to go out and do it. Some of them are staying in our local community, some join our faculty, some go on to do fellowship because they would like to do C-sections. Others are indeed going to more rural areas like Eastern Shore of Maryland and North Carolina.
One of the things I like about our community is that we have role models within the community that practice obstetrics in different ways. So, you don't have to join the faculty in order to continue doing OB. You can join a local FQHC where they continue to do obstetrics, and there are several private family practices in the area where they do obstetrics, and they practice in different models. Sometimes they follow their patients into the hospital. Sometimes they do all the prenatal care and pass off to the inpatient provider at some point. But there are several different models of that happening in Lancaster. So folks have an opportunity. You can sort of see yourself in the future doing it differently. I think a lot of people think if I want to do OB as a family physician, I have to be a faculty member, but that's not really the case.
Thank you all.
Joytan, do you have another question?
Yes. I wanted to ask, I see there are a lot of strengths in your program. Do you have any weakness, and what are you doing to overcome it?
I mean, every area of concentration that we have at our program, and there are, like Pam said, there are more than 20, that represents a weakness that we had previously that in one way or another, a resident or a faculty member said, I'm going to take this on as a PI opportunity and change the residency. And one of the things that I appreciate about the leadership within our residency program is that we are open to change and open to adapting to the changing medical landscape. So yes, we have weaknesses, and every new class of residents that shows up helps us identify those, and we work on them, and that's what PI process improvement is all about. So I think we're more and more aware of weaknesses every year. So
I also wanted to add that the faculty are always asking for our feedback. Even as an intern class, we just met with Dr. Vanenchek maybe 2 weeks ago, and she asked us all, what could we be doing better? So it's something that they're constantly asking us about.
So feedback, basically. Thank you so much.
Annette?
Hi, good afternoon. My name is Annette. I work as a clinical assistant with sports medicine here, LGH. So thank you for having me on board. My question is in regard to, you mentioned that you sometimes see high-risk patients. So for the residents, is there a set number of management for postpartum, complications or antepartum complications that they have to go past to be able to pass the program, or is there or it doesn't really matter when it comes to, complications management? Thank you.
There are certainly no numbers, and there is certainly no lack of complications and complexity. Our residents feel very comfortable managing preeclampsia, diabetes, postpartum hemorrhage. Basically, our residents care for very complex patients that really any place else would be managed by OBGYN residents, because our residents are the only ones in the hospital, and because of the population that we care for is so high risk. These are patients that went out in the community, in most communities would be transferred, because if these are patients in a rural area, you're not going to take care of them in your rural critical access hospital. They're going to need to be stabilized and transferred. So our residents really get to manage the most complex things, and so they're going to feel very comfortable identifying those things early and helping to prevent them, stabilize them, so that way they can achieve the proper level of care.
Okay.
Yeah, but
Thank
we
you.
take care of a lot of substance use, HIV, hepatitis, and we are working together with our OB/GYN colleagues to decide when and if surgical delivery is necessary. How can I manage? We take care of a lot of, for example, vaginal birth after C-section, and I think learning the skills that are necessary to do that makes us confident in most settings when our residents leave here. So,
Okay, thank you.
It looks like we're at the 7 o'clock hour, so I think we're going to have to end it there. We do have your email addresses, and we can certainly put hours in the chat. So if you have specific questions that you would like to email us. And then Scott, will people have the opportunity to see the transcript, or how best should we do that?
We will be putting the recording of this up on our website. And if you need to connect with this program or any other program, you can always just email me at the FMEC, and we will help you make a connection.
Thank you so much, everyone. This hour went really quickly. I really enjoyed talking with all of you, and thank you for your engagement and questions.
Thanks, everyone.